Hello, welcome to Holmes Community College Paramedic Program. Glad you're here. Tonight's lecture is ECG Waveforms that we can monitor with a cardiac monitor using lead 2 from Einthoven's triangle. Einthoven used PQRST to identify the different waveform, and sometimes you, to identify the waveforms, and he chose those variables because they were in the middle of the alphabet and they were away from the commonly used X and Y's in algebra and whatever they use in geometry. So Einthoven's triangle, lead 2, we're looking across the face of the heart. We're going to use the right arm lead and the left leg lead. And there's a heart in the middle. And there's an SA node, an AV node, a bundle of His, a left and right bundle branch. When the electrical stimulus starts at that SA node, as it does with the depolarization of the atria, and moves down to the AV node, brief pause, the bundle of His, and left and right bundle branches, which cause ventricular depolarization, which is the contraction of those giant muscles that make up those ventricular chambers and inject the blood either from the right side to the pulmonic circulation or from the left side to systemic circulation. We can see a positive waveform as the electrical energy moves from the SA, AV, down that bundle of His and left and right bundle branches that are associated with each of those functions of the heart. We use the P, the Q, the R, the S, the T, and the sometimes U variables to identify what each of these deflections on the EKG monitor represent. As we move toward a positive electrode, we will see electrical tracings that move above an isoelectric line. We know what that one is. Everybody knows that's asystole. There is no electrical energy being developed. There's no automaticity. There's no depolarization or repolarization when we see the isoelectric line, the asystole. There is no electrical energy. What we do see, though, when there is depolarization and movement from that electrical energy in the heart, and that's the left leg lead. When that SA node begins, the electrical cascade is an all or none that moves through the internodal pathways and causes atrial depolarization. That's where the P wave comes from. And the P wave is round and upright. Starts out on the isoelectric line. It is associated with, on a mechanically working heart, the atrial depolarization. The first negative deflection after the P wave is the Q wave. That is the beginning of the ventricular depolarization. After we moved from that SA node to the AV node and down the bundle of His and left and right bundle branches, we have stimulated the influx of the sodium, the efflux of the potassium, the influx of the calcium, and caused ventricular depolarization. That first negative complex, the first negative movement from the isoelectric line after the P wave is the beginning of the QRS complex. That is the Q wave. The R wave is the first positive. The S wave is the first negative. We came below the isoelectric line. We call them positive if the deflection moves above the isoelectric line. We call it negative if the waveform moves below the isoelectric line. We come back to the isoelectric line. That is the completion of the S wave. Then we're back on the isoelectric. There's a T wave. And that is the representative of ventricular repolarization. The sodium-potassium pump has moved the sodium that was inside the cell, and the calcium moved back out as well. That was inside the cell during the ventricular depolarization, moves back out, and this is also when the potassium that had efflux has been moved back into the cardiac cell. The T wave is ventricular repolarization, and we're back on the isoelectric line, and that is the beginning for the next atrial stimulation, the next P wave. So we got a P wave here, we got a Q wave here. This entire complex is a QRS, and then this is a T wave. There are some segments in here. The beginning of the P wave to the beginning of the QRS is the PR interval. The beginning of the Q wave to the end of that S wave is the QRS complex. That is the entire ventricular depolarization. The point where the S wave returns to the isoelectric line is called a J point. We'll talk about that much later when we're doing 12 leads. It's really important when we're trying to decide if someone's having a heart attack or not. That J point, where that S wave meets the isoelectric line and moves into the T, which is the T wave is, like I said, ventricular repolarization. So each one of these has some normal values associated with the amount of time it takes for them to occur. So this PR interval, and these are just about memorization, the PR interval in time should be 0.12 to 0.20 seconds. The QRS should be 0.04 to the outermost limit, 0.12 seconds. We'll do that QT interval later on when we do the 12 leads. Didn't come up much right at this point as far as being able to determine the rhythms. But without knowing these normal limits, we'll have you're not going to be able to interpret rhythms and arrhythmias. So 0.12, 0.20 on the PR interval. What is 0.12? One tiny little block on your EKG paper is 0.04 seconds. So it's between 3 and 5 of those tiny little blocks. The smallest block on the graph paper equals 0.12 to 0.20. On the QRS, it's a narrow complex. When those ventricles contract, they contract quickly within 0.04 to 0.12 seconds, either one tiny block up to 3 blocks. If it's greater than 3 blocks, something is outside of normal limits. If the PR interval is less than 0.12 or greater than 0.20, it's outside of normal limits. There's something else outside of a normal working heart happening with the electrical system. So, again, for the Itover's triangle, we're going to use lead 2 most often because the greatest amount of electrical energy on a normal working heart starts in the right atria, moves from the SA node, internodal pathway, AV node, bundle of His, left and right bundle branches. So it's moving from a negative electrode, which is the right arm, toward a positive electrode on the left leg, and that's going to give us the most pronounced deflections, positive on a P, positive on that R right there, positive on that T, and that'll give us the easiest way to see the waveforms on the cardiac depolarization, atrial or ventricular, or repolarization of the ventricle. We don't see atrial repolarization. It's likely hidden inside this QRS. Well, not likely, it is hidden inside this QRS. And that's all for this one.